Our next section in the Pons, the main new information here relates to the trigeminal nerve and different trigeminal nuclei that we have not seen before. So starting with pathways, we still find our cortical spinal tract occupying this location in the Pons. I will only point out the things that are starred in your handout. So remember the other midline pathways, but we'll just highlight here the medial longitudinal fasciculus, still located in that position. And again, just notice how close these are together. So if we have a demyelinating lesion here, like in multiple sclerosis, it's very easy for that patient to develop a bilateral internuclear ophthalmoplegia. We can see the two cerebellar peduncles here, the superior cerebellar peduncle, which remember predominantly has information going from the cerebellum back to the contralateral motor cortex. And then I forgot to list this in your handout, but certainly you should know here that this is the middle cerebellar peduncle. And we've said before that this is entirely information going into the cerebellum as part of the cortico-pontocerebellar tract. All right, so a large nucleus we can see right here, and this is the motor trigeminal nucleus. Okay, so up to this point, we've only seen the spinal trigeminal nucleus and tract, but now we can see the motor trigeminal nucleus, and I'll go over the function of that in just a minute. A smaller nucleus right up here, you can see it's circled over here. Sorry, my yellow highlighter kind of obscures that. But this is the mesencephalic trigeminal nucleus, and we'll go over the function of that. And then we also have here kind of out laterally, here it's circled over here, the principal sensory trigeminal nucleus, sometimes called the chief sensory trigeminal nucleus, and we'll describe the function of that as well. Notice that we can see these finger-like projections here, little black finger-like projections going into the motor trigeminal nucleus here. We can see it over here, and that is the actual trigeminal nerve itself, as its kind of finger-like projections either enter into or come out of these various trigeminal nuclei. We can still see the fourth ventricle of the cerebellum here. The pontine nuclei here scattered around the corticospinal tract. And so you want to relate the pontine nuclei to the middle cerebellar peduncle, because the pathway, remember, is called the cortico-pontocerebellar tract. It goes from the cortex to the pons, and it gets to the cerebellum through the middle cerebellar peduncle. Lastly, this doesn't show up very well, and it's not starred, so I certainly would not ask you to identify this, but the locus ceruleus is about in this location here and over here. All right, and so remember the locus ceruleus produces norepinephrine. All right, so let's go through these trigeminal nuclei in terms of their function. So the motor trigeminal nucleus we've already talked about supplies the muscles of mastication, the chewing muscles, temporalis, masseter, and the pterygoids. And we've already discussed that if you have a lesion of the trigeminal nerve or of the motor trigeminal nucleus, you're going to get chin deviation, and it's going to deviate in the direction of the paralyzed side, and you can observe this when the patient opens their mouth. So it's just like a hypoglossal lesion in that the tongue deviates toward the side of the lesion. Now, the mesencephalic trigeminal nucleus is very unique because it's the only ganglia, it's really part of the peripheral nervous system that gets pushed into the central nervous system. So it's a displaced ganglia. And the mesencephalic trigeminal nucleus you want to associate with proprioception, especially of the jaw muscles. And so just like when you think of checking the patellar reflex, where you stretch the tendon and that then activates via the dorsal root ganglion an anterior horn cell that goes back to the muscle, like the quadriceps muscle. This is the same function of the mesencephalic trigeminal nucleus, but now it relates to the face. And so just think of chewing or talking. It makes sense that you need to know where those muscles are in space. And so with every jaw movement, for example, the mesencephalic nucleus is activated, and it is sitting right next to the motor trigeminal nucleus. On this diagram, it may look like they're far apart. They're actually not. They're right next to each other. And so that then this will feed right back to the muscle that is stretched. Okay? So it's very important for chewing, accurate chewing and talking. And in addition, we can assess this nucleus by the jaw jerk reflex, which we talked about in the neuro exam. Remember, you have the patient open their mouth just a little bit, and you tap their chin with your reflex hammer, and the jaw snaps back up. So that reflex then, the afferent is the mesencephalic, the efferent is the motor trigeminal nucleus back to the jaw muscle, which then contracts. All right, the other trigeminal nucleus we pointed out is the principal or chief sensory trigeminal nucleus, and this is tactile sensation for the face, so vibration and light touch predominantly. Okay. In addition, we can get information about this nucleus by doing the corneal reflex. So we mentioned this in the neurologic examination, that when you touch the cornea, both eyes should close. And that happens because the information goes in through the ophthalmic division of the trigeminal nerve back to the chief or principal trigeminal nucleus, and then to the facial nucleus, and the eye closes. Okay, but really it's happening, here's the chief sensory trigeminal nucleus, goes to both facial nerve nuclei so that both eyes close normally. Okay, and so the most common reason we check a corneal reflex is in a patient who's unresponsive, because remember, all of this is happening in the pons. So the corneal reflex is a good way to assess function of the pons. So if someone's unresponsive, you touch their cornea, both eyes close, that tells you that the reason for the coma is not a pontine lesion. And we previously discussed how, with a facial nerve lesion, that's the output pathway. So if you touch the cornea in this eye and the ipsilateral eye or the direct eye closes but the contralateral doesn't, then that tells us we have a facial nerve neuropathy here on this side. Now, we've sort of mentioned here and there different parts of the auditory pathway. In fact, all of these we have mentioned briefly, so I thought, even though we have a whole lecture on auditory where we go into this in more detail, I'm going to bring this up and mention one new nucleus and pathway that'll show up on our next slide. So, of course, we have the cochlea, the eighth nerve, which we've pointed out, the cochlear nuclei that sort of enter into the dorsal medulla and lower pons, we've shown you. The superior olivary nucleus is one that I need to go back and point out. And then we have the nucleus and tract of the lateral lemniscus. And so don't get this confused with the medial lemniscus. Remember, that's vibration and proprioception. Lateral lemniscus is an auditory pathway. Okay, then we have the inferior colliculus. We've already talked about how that's important for sound. And the medial geniculate body or nucleus is the thalamic nucleus involved in sound. And then we have Heschel's gyrus. So now I need to back up because I realized I didn't point out one thing here, and that is the superior olivary nucleus. I won't ask you to identify it. It's a very small nucleus right here. We can see it over here. But the superior olivary nucleus, not the inferior olive, remember that has to do with cerebellar function, but the superior olivary nucleus is important for sound localization. And so what happens is when we get an auditory stimulus, it's going to strike the right ear and the left ear at slightly different times. Yet we're very good at precisely being able to localize sound. And that function is by the superior olivary nucleus. So it's very good because sound is going to strike the nuclei at slightly different times, and they also share information back and forth. And so associate this with sound localization. If you've ever had the experience, you're at a party or something, you're talking with someone, but you really want to hear what someone on the other end of the room is saying, and you kind of focus in on that, well, the superior olivary nucleus would be somewhat involved in that process. Okay, skip through these again. Now, our last section here in the Pons is through the fourth nerve. Remember, it's the only cranial nerve that exits the dorsum of the brainstem. So it's the only time we're going to see a nerve coming out this way. If you see that, even if you're totally confused, you don't know where you are, it has to be the trochlear nerve. All right, so again, going through the pathways, we have the corticospinal tract, which has always been about in this location. Okay, the medial lemniscus, which, remember, the last couple of sections, it's lying flat. And here, this is the first time that I've asked you to be able to identify the spinothalamic tract, because it occupies a fairly distinctive location here, right next to the medial lemniscus. So remember, this is all sensation from the arms and legs, vibration, proprioception, pain and temperature, and it's all headed to the VPL of the thalamus. Okay, now the reason I brought up auditory pathways in the last slide is that I wanted to here highlight the lateral lemniscus. Now there's a nucleus of the lateral lemniscus as well, but all sound is going up through the upper pons and into the midbrain as the lateral lemniscus. And then on the next slide, we will see the inferior colliculus, which is where this will synapse. Okay, we still have here the medial longitudinal fasciculus, which always occupies this medial location. Okay, and the corticopontocerebellar tract, it's been there the whole time, but it's rather indistinct. So this is the first time I'm really pointing it out here. And the corticopontocerebellar tract is synapsing in all of these white, pontine nuclei. So here we can see the pathway gonna synapse there, and then it will cross over in the middle cerebellar peduncle, which we saw on the last slide. Okay, now the superior cerebellar peduncle is right here, occupies most of this very large pathway here. On the next slide, we'll see how the superior cerebellar peduncle, right and left, come together right in the midline. Okay, and then I've already pointed out the trochlear nerve here. Here's the cerebral aqueduct. Okay, and the next slide we'll see the pineal gland sitting right here. And so it's not hard to imagine that a pinealoma tumor could compress the cerebral aqueduct and give the patient a non-communicating hydrocephalus. Still see a lot of the reticular activating system here. Remember, so much of that is in the this dorsal portion of the pons. The periaqueductal gray, which is all around the cerebral aqueduct, is right here. And the periaqueductal gray, which we'll talk about in the pain lecture, is loaded with opioid receptors and will be very important when we think about, giving medications like morphine and pain response.